joining us again this morning. I'm going to try to go briefly through the introductions because we're a little short on time, and we want to have time for Q&A at the end. Our next speaker is Dr. Josh Milner. He is the Section Chief of the Allergic Information Unit in the Genetics and Pathogenesis of the Allergy Section of the National Institutes of Allergy and Infectious Diseases. That's a mouthful. He gave a brief presentation on his research at last year's conference, and it left the audience eager to hear more. We are lucky to have him here back again to talk about the exciting work he's doing at the NIH. Please join me in giving a warm welcome to Dr. Josh Milner.
All right, so thank you so much for taking the time to listen this morning. I'm going to give you an update about what we've been working on. You'll notice that some of the slides I'm going to provide are not in your packet there, and that's because some of this is not yet published. We think that it's probably going to be sort of something that's going to be impactful, and we don't want to jeopardize that publishing process. And so if we can keep what I'm going to talk about out of the social media for a while, thank you, I appreciate it. You can tell your friends all you want. You can go back to the good old-fashioned talk on the telephone. Just don't retweet your phone conversation. I'm thrilled about Dr. Afrin's introduction about the mast cell activation syndrome because I don't have to say much at all now about that, which is just though, but then just to point out that indeed I'm calling somatic clonal mast cell disorders is the mouthful for what is sort of like mastocytosis, what Dr. Afrin had spoken about. That there's a set of symptoms that those patients can get. And on the other hand, there are patients who have a genetic syndrome called Ehlers-Danlos syndrome hypermobility type, which is interesting. That we call it a genetic syndrome. It certainly looks like you must have been born with it and you can have a family history. But in almost no cases do we know a gene why it happens, unlike the rest of Ehlers-Danlos syndrome types. In that case, you can have hypermobile joints and retained primary teeth, and scoliosis, your spine is a bit bent, and pectus, where your chest can go in, and a number of other issues that can end up happening with your bones and joints. And so here on the one hand is something where you've acquired later in life, this mastocytosis thing. On the other hand, you have the connective tissue problems which you were born with and are genetic. And what's interesting is that in both of these cases, there's a shared series of symptoms, I've put at the top here dysautonomia and POTS, that can happen regardless of which is the cause of what you have. Either it could be mastocytosis and there's nothing wrong with your bones and joints, or bones and joints and there's nothing wrong with your mast cells. Abdominal pain, so chronic pain issues, cognitive issues, some bruising and bleeding, and anxiety and depression are shared by both, even though they come, it would seem, from extremely different causes. Okay? And this is just a picture, by the way, of when you have mastocytosis. Many folks have a rash here. It's called urticaria pigmentosa. If you scratch one of those things, it'll turn into a hive. So just the point is, it's very clear. It's not a subtle thing when you have urticaria pigmentosa. And so I just showed that picture so it's clear what mastocytosis can look like. There are people who don't have the rash, who have mastocytosis. Now, when you get, as Dr. Afrin had mentioned, one of the main things you look for when someone has mastocytosis, out of the 18 billion things that a mast cell can make, you look for something called tryptase. And that's because it's mostly made by mast cells, and very few other cells make it in a typical individual. We all have just about all of us, have some measurable tryptase floating around in our blood, and it tends to go up when you have a bad allergic reaction, usually to a drug or to a bee sting. It's weird with foods, it doesn't happen as much, which is frustrating to the rest of us. It's elevated at baseline when you're not having a problem in people who go on to have bad bee allergic reactions. So you could have never had a bee sting, but if I measure your tryptase and it's a little high, you are more likely to have a bad bee sting reaction than someone whose tryptase was normal. Again, you can see it in mastocytosis. It's very, very elevated, not usually just a little elevated. And, as Dr. Afrin mentioned, there is a subset of patients who get the term mast cell activation syndrome who do have a high tryptase because in defining what mast cell activation syndrome is, they want to see a lab that's high, right? But let's be clear, we're making this up. Okay? So that's why you'll see it in, I've read literature. I don't like literature at all. When it comes to this, because it just doesn't know what it's talking. That may not be wrong or right, just we don't know. I mean, let's be honest about it. I think Dr. Afrin said that pretty clearly before. But the point is, you'll find people who get the label MCAS because their tryptase was high, and they have a bunch of symptoms that are consistent with mast cells degranulating. The thing is that 4.5% of the population has a, quote, high tryptase. How do we define a high tryptase? How do we decide what a high tryptase is? Statistics. Nothing to do with people's health, okay? Just there's a certain number of standard deviations from the average. That's what a high tryptase is. That's what makes it red or an H next to it in your lab, like everything else, and sets everybody crazy when that's just what a statistic said was high. It doesn't mean anything for your health necessarily. But 4.5% of the population, that's 1 in 25 people, have a high tryptase. That's sort of already known for a while, but we didn't really pay a whole lot of attention to that, right? Who the heck cares that you have a high tryptase if you weren't looking for it because of whatever symptoms that you ended up having? Okay, so there was a study that was done, and I showed this last year, that looked at people who do just at baseline, walk into an allergy clinic and they have a high tryptase or they don't have a high tryptase. What are the things that people who have a high tryptase have that people who don't have a high tryptase don't have? And it's flushing, and it's angioedema, swelling, and it's gas, and abdominal pain, and diarrhea, and muscle aches, and swinging mood, and vertigo, palpitations. All these things can happen in people who have a high tryptase compared to those who don't. Now, let's be clear that this was an allergy clinic where they were doing this. And so, and fatigue, by the way, number one. But just to show you that the controls, it's not like people walk around with a low tryptase are all perfectly fine, right? There are plenty of these symptoms happen in lots of the population. It just is, there's an increased risk for them happening. And some of them, there's a far increased risk for them happening if your tryptase is higher. Okay? So we found at the NIH a whole bunch of families in whom the tryptase was high. Okay? So these are pedigrees. If it's filled in, if it's black, that means that the person was affected. And you can see it's dominant. So there's a parent in every generation, and with a child who is affected if there's a grandkid who has it. So it's every generation, boys and girls equally affected. A dominant inheritance pattern of high tryptase. And we were very excited because if that's the case, the chances are decent that we could find a gene that is causing that. And maybe that will have some application to what's going on in the vast world of the mast cell activation syndrome. And the truth is that these patients, many of them came in with every single symptom that Dr. Afrin listed or that you could look up on the web. They had just about all of them, flushing and itching, abdominal pain, all that sort of stuff, and the connective tissue problems. There were lots of folks, about a third of them, who were hypermobile joints, who had to have teeth pulled when they were young, and when their adult teeth were coming in. And so that was completely, it seemed like that one would have nothing to do with the other. A high arched palate, maybe some scoliosis. They had both of them. Not everybody had every symptom, and some people had zero symptoms who had the high tryptase. Now let's get clear. There are tons of different ways that you can get flushing and tachycardia and loss of blood pressure, belly pain, and even hives that have nothing to do with the mast cell. Absolutely nothing to do with the mast cell. You can get all of those symptoms. I want to make that very, very clear. And the other thing is that tryptase itself can do all sorts of things that we attribute usually to releasing histamine. Okay? Tryptase can act on blood vessels to make them dilate. It can act on blood vessels to make them leak out fluid and cause swelling. It can act on nerve endings to cause pain of all sorts. Okay? Tryptase can do a lot of things. And tryptase can make your response to histamine more pronounced. Okay? So you might have a regular amount of histamine, so your lab was normal for histamine or whatever it was, and the tryptase can actually make you feel it much easier. It basically can prime you to be more sensitive to everything, even though what's happening to you is the same thing that's happening to anybody else. That's what tryptase can do. As Dr. Afrin mentioned, mast cells can respond to stress hormones and make it easier for them to release. And so this mix of stress and illness and mast cells is a potent one, right? It is not something that's in your head. It's your head is doing things to mast cells, and then your mast cells are doing things back to your head. And other parts, not just your mast cells. And I just showed this other article that when you have to have the receptor for tryptase to get sickness behavior when you get an infection. So like if you get, they actually injected mice with inflammatory mediators, and they get depressed and they sort of become reserved and all sorts of things happening. If you don't have the tryptase receptor, they don't act that way. It's literally called sickness-like behavior, and you probably can think of a lot of things where you sort of get down when you're sick, but then that can happen all the time. Well, imagine if that tryptase receptor is just firing all the time, you don't even need to have a virus to have this problem. Okay? And just what a finer point on it, getting up here and talking is actually worse than an electric shock from the point of view of your mast cells releasing stuff that causes, in this case, an IBS-type problem. Okay? So actually, I've done this enough times, so it's not an issue right now. But for people who are doing it for the first time, their guts get leaky by worrying about speaking in front of 1,000 people more than getting a shock in their skin. Okay? And actually, if you take cromolyn, which is one of the drugs that you can take for mast cells, you can prevent the leaky gut that's associated with getting up here and speaking. Okay? So that's actually just to put the point on how our brains mess with our bodies. I think it's an important point. But here, there's a very specific physiologic thing that's happening. Okay? All right. So the symptoms that happen, I just have to make it clear. I don't know that in our disease that we're studying here that patients have activated mast cells. I have no evidence of it whatsoever. I have some patients who have those high mediators at all those labs and everything like that, and I have other patients whose all their labs are normal except that their tryptase is high. Okay? But it may well be that it's the response, not what's being made. That's the problem. So I want to make that clear. And that's why I think getting these diagnoses, it's a little tricky to say that if I have all negative labs, then I should just stop right there, because I'm not sure about that. We don't know quite what to do for you, but I wouldn't say you don't have this problem. Also, finding too many mast cells in the skin, sometimes you see it, or the gut, sometimes you see it, and sometimes you don't. And again, I have to reiterate that an overactive response could be the issue that's happening here. Okay? So I think I've made my point. It's not in your head, but the two of them are doing things at the same time in what we thought was a rare disease. Okay? Oh, they loaded the wrong talk. So, okay. Yeah. So what's missing here is the following. What's that? Yeah. Okay. So what's missing here is the following. In our families, there was a single gene that caused everybody's high tryptase to happen. And essentially, it's a duplication of one of the tryptase genes. They have one extra copy. And that extra copy is the only reason why they have their high tryptase and all the symptoms that they end up having. It's a genetic explanation for why this thing that looks like a mast cell activation is happening in these patients. They're making too much tryptase. That's why we care a lot about the things that tryptase can do on its own, not having to do with whether or not the mast cell gets activated. It could, or it could not. We don't know. Okay? Too much tryptase is being made because you have too many copies of a gene that makes tryptase. That's what happens in these families. The thing that's important, that I think is a very big deal about that, is remember I said that 4.5% of the general population has a high tryptase? All 4.5% of them have this genetic mutation. Okay? 1 in 25 people carry a common change in their DNA that makes them make too much tryptase. And that causes these issues. So we actually went into a normal population at the NIH, and we found 9 people who had a high tryptase out of a couple hundred, and we spoke to them. 3 out of those 9 people had dysautonomia, POTS, flushing, itching, belly pain, teeth had to be pulled when they were children, and hypermobile joints. Okay? So it's not rare at all. This is one cause of the things that Dr. Afrin was talking about. One genetic cause. It does not affect everyone. 2/3 of those people were completely fine. But that's about 1% of the population who might have their issues that we've just discussed explained by this single genetic problem. So that's the one thing that's not there. This is my last slide. We don't know what is a direct effect of mast cells being released versus, again, the tryptase doing stuff and just potentiating whatever a typical mast cell would do. I do this, I can make a mast cell degranulate, believe it or not. I don't respond to it, but if you have a high tryptase, maybe you will. See? In the meantime, we manage symptoms. It's completely trial and error. There is not a single trial for the mast cell activation syndrome or disease, that Dr. Afrin was describing, that tells us something that actually we know works. There isn't a placebo-controlled trial. We don't have one. So we're trial and error. Hopefully, we're going to figure those things out soon. And of course, the very interesting question is, if we block tryptase, can we block all these issues in patients like these? And then what do patients like these who have the high tryptase, what do they have to do with those who don't have a high tryptase but have the same presentation? It's something we're working on right now. And that's it. Here's my gang. Thanks.
Just trying to stay on schedule. I think Dr. Milner has to leave pretty quickly after the talk, or maybe even right now. But if anybody has a really urgent question you have to get to him, maybe chat with him outside or something like that. Is that okay? Okay. So our next speaker is Dr. Paola Sandroni. She is a professor of neurology at Mayo Clinic and the director of Mayo Clinic's Autonomic Lab. We're very grateful for the time and talent that she lends to Dysautonomia International. She's telling me to hurry up. She's one of our founding medical advisory board members, and she does a lot of cool research and teaching and other great things for the dysautonomia community. So thank you very much for coming.
All right, so what I'm going to talk about today actually is not my work. It's work of my colleagues that presented this not long ago. Anyway, it's published if anyone is interested. And Lauren wanted me to update you all a little bit on the issue of a patient with autoimmune gastrointestinal dysmotility. So, as you see, large group of people. Is this a pointer? Yes. So neurology, all these are GI folks. And yes, it's a fabulous group to work with. I share a lot of patients with them, needless to say. So the issue of GI dysmotility is a big one, and we have a fabulous group of immunologists at Mayo that have discovered gazillions of autoantibodies, and probably will discover more. So what we think is not autoimmune now, maybe 1 year from now, 2 years from now, 5 years from now, will change completely our views because we have found a new autoantibody. So one of the interests was about the patient with chronic intestinal dysmotility, which obviously has a major impact on the quality of life. And most of the time the treatment is not super successful, let's put it this way. And we've started a few years back when the acetylcholine receptor ganglionic antibody was discovered. We looked if these patients, particularly with the chronic pseudo-obstruction, had the positivity or not. And the study was really inconclusive. There was some positivity in some folks, but was really biased because there was only a certain number of patients that were tested, not the whole population. So it was difficult to draw any conclusion. But clearly that made us look into this a little bit further. So now we're pretty much testing just about routinely every patient that comes through with a GI dysmotility to see if this could be an expression of an autoimmune dysautonomia, essentially. And you can have that just in isolation. The enteric nervous system, it's a world on its own, and basically it's called the second brain, not by chance. And there's actually a beautiful cartoon, I forgot to load it, but anyway. So you can truly have everything GI and nothing else, because it's really a world on its own. So they have started then, based upon this study, they want to do an immunotherapy trial to see if, well, do these patients get better or not. So Here is the data of a study that they did looking at the utility of a trial of immunotherapy in patients with suspect autoimmune gastrointestinal dysmotility. And the study that they used to quantify the efficacy was really a transit study, essentially, to have some objective evidence of efficacy. So they looked for, they studied 15 subjects that fulfilled the following criteria: prominent symptom of gastrointestinal dysmotility with documented scintigraphic and manometric evidence of the dysmotility, not just a self-report. You'll be surprised how many patients think that their gut and their stomach doesn't work and the study is normal. So our own assessment sometimes is very misleading for a variety of reasons. I have really no time to go into it. But and they looked for patients that had serological evidence of personal and or family history of autoimmunity. If you have an autoimmune disease, you are much more likely to have another. It's just the nature of the beast. And if you have a strong family history of autoimmune disorders, you are at very high risk of having an autoimmune disease yourself. And it doesn't matter what your family had and what you have, it can be totally different but still autoimmune. So these patients were treated on a trial basis, 4 to 12 weeks of intravenous immunoglobulin, 9 patients, methylprednisolone, 4 of them, and 2 of them had both. So symptoms of presentation, the most consistent one was constipation, which is the most classic one and actually the easiest one to test from a motility study standpoint. 11 of them had weight loss as a consequence of it, nausea and vomiting, same, bloating, 9 of 15, and early satiety, 4 out of 15. A group of them also had other symptoms that were not related to the gut. 9 patients of 15 had orthostasis, 4 had blurry vision, 2 had dry mouth, 2 had sweating difficulties, and 2 had urinary difficulties. 8 patients out of the 15 had a personal and or family history of autoimmunity. 80% of the patients had positive neural antibodies, and there were various types which are listed here. So 5 were the acetylcholine ganglionic receptor autoantibody. 3 was the antineuronal nuclear autoantibody type 1, also called anti-HU. 2 had voltage-gated potassium channel complex antibodies, and 2 had peripherin IgG. Cancer was detected in 3 patients. Pre-immunotherapy scintigraphy revealed a slow transit, and 11 out of the 13 were evaluated actually. 6 had gastric abnormalities, 6 had small bowel abnormalities, and 7 colonic abnormalities. Manometry studies pre-immunotherapy were abnormal in 8. Autonomic function was abnormal in all 12 patients tested. Post-immunotherapy, 13 of the 15 had subjective or objective evidence of improvement. And I don't know how well this projects, but essentially we have here, I guess the column we can try to focus on are these that are shaded blue. And these are really each single patient. So as you see, the improvement here varies quite a bit from 28% to really irrelevant. 1% is basically within the reproducibility of the system. The one that responded the best was actually the small bowel transit, with a change in most of them that was quite substantial, while the colonic motility response essentially 0. All patients were reevaluated also with other testing, and this is an example of a couple of, one patient that had a sweat test. The patient is supposed to be like this before the test and dark afterward, so this patient responded beautifully, not just in the gut, but also in the sweating capacity. This may be a little bit more difficult to interpret, but this is a scintigraphy study. This was a patient that had the scintigraphy, the kind of pooling, and then afterward managed to go more diffusely. This is the colon. This was a patient with a small bowel. Again, everything was pooling in one spot, and afterwards start moving, which is what you want to see. You don't want the meal, which is loaded with with the active nuclear material, to sit in one spot. Means that the food is just sitting there and not moving. And this one was a gastric transit. Again, the food is supposed to leave the stomach within a certain amount of time, depends upon the meal, but usually within 1 or 2 hours you want to see things moving. And so there was some movement in the duodenum, but a lot was sitting in the stomach, and after treatment, almost nothing was sitting in the stomach and was moving through the gut. So that's what you like to see. So this study showed some, I would say, encouraging data. And that's the first objective evidence that immunotherapy can reverse autoimmune gastrointestinal dysmotility, and underscore the importance of considering an autoimmune basis for acquired idiopathic gastrointestinal motility disorders. Symptomatic improvement was generally accompanied by improved gastrointestinal motility and autonomic function on repeated scintigraphic, manometric, and autonomic testing. Again, this is clearly preliminary data, but gives us some support and some encouragement to continue down this path, looking for tests and surrogate markers of improvement for future randomized controlled clinical trials. And that's it. So I don't know if you have time for questions or not, but
What time does the session end?
11 o'clock. So
Yeah, like 2 minutes question.
if there is anything specific. Again, these are clearly preliminary data. And it's obviously is not for everyone. And I guess the biggest question that sometimes we have is, when we have a positive autoantibody, what does that mean? Is that pathogenic or not, or it's incidental? That's always $1 million question, particularly now that we have a long panel. So, anyway.
Question. Any information on follow-up on those individuals that appear to respond to the IVIG in terms of sustainability?
That's all I have thus far. Again, probably it's very early, but apparently they responded. Sometimes it's a monophasic thing, so what they told me was that it was sustained. So, yeah. Okay, Lauren, you're next.
Do my intro?
Should we introduce you?
No, just kidding. Is the immunotherapy the IVIG?
Again, 9 were IVIG, 4 was methylprednisolone, and 2 received both.
Thank you. Yep.
I might need some AV help getting to my slides. I'm not sure where they are here. Huh? Okay. Good morning. As you guys know, my name is Lauren Stiles. So I'm not a doctor or an official researcher, and I'm feeling very under-credentialed after the last 2 speakers. But my local neurologist on Long Island is Dr. Mark Guteslat, and the way the scheduling worked out, he ended up lecturing next door on MS and autonomic dysfunction in MS right now, so I'm doing this one solo. But I worked with him on some research, and I'm just going to present our findings. So we looked at novel early Sjogren's antibodies in idiopathic dysautonomia. And as many of you know, Sjogren's is typically diagnosed with SSA or SSB antibodies, and sometimes a minor salivary gland lip biopsy. But a lot of doctors are reluctant to order that lip biopsy, or don't even know where to send the patient, because there aren't too many doctors who are good at doing them. And so a lot of doctors end up relying on the SSA, SSB test And it's not entirely accurate just to rely on that. So my disclosures, Dr. Gudis' disclosures. So just a quick overview of what Sjogren's is. It's a systemic progressive autoimmune disease and a common cause of autonomic and sensory neuropathies. There are some conditions where it may not really matter if you're diagnosed or not because you're just going to have it anyways and there's not much they can do, but it's pretty important to know if you have Sjogren's because you do need treatment and long-term follow-up care. The average age of symptom onset is 52, although that's when it sort of becomes really obvious. If you talk to a lot of older women who've been diagnosed with Sjogren's, they'll tell you they've had some kind of weird immune stuff going on since they're, often since their 20s. I was diagnosed at 31, so I was younger than average, and I can actually look back in my medical history and see some sort of just unusual things that were going on, but nothing that was severe enough to lead to a diagnosis. There are 4 million Americans estimated to have Sjogren's, and 75% of them are undiagnosed. And similar to some forms of dysautonomia, it's very female predominant. The average diagnostic delay is 10 years. That's improved a little bit because the Sjogren's Syndrome Foundation has really, really been pushing for increased awareness, doing a lot of physician education and outreach. And that's actually part of, I've learned a lot from following their organization, and they're very professional in the way they do things. And part of our push to reduce the diagnostic delay for POTS is actually modeled on what they've done for Sjogren's. So the traditional thinking on Sjogren's, a lot of doctors, even rheumatologists, will tell you, it's older women, they have severe dry eyes, dry mouth, joint pain, and fatigue. That is true. Some Sjogren's patients, that's how they present. And they have positive SSA and less often SSB. But that is not everyone who has Sjogren's. And even after I was diagnosed, I had a rheumatologist who was allegedly a really good rheumatologist in New York City at a big hospital. I said, "You're too young to have Sjogren's." And he wouldn't even look at my test results. And I know I've met 13-year-olds that have conclusive Sjogren's done by top Sjogren's researchers. So it's not as common in young people, but it can happen. So sometimes on the patient support groups, we hear patients saying, "Oh, my doctor wouldn't test for it because there's no treatment anyway." That's not true. And then sometimes doctors will say, "Just buy some mouthwash and eye drops and you'll be fine." And that would be great if it was true, but it usually isn't. So the reality is it can occur in younger children, and it can present differently in children and in younger adults. And in my own case, having an onset around age 31, I never really had severe dry eyes or dry mouth. I did not go to the Dr. Shamali was the neurologist who diagnosed it. I never went into him and said, "I have dry eyes and dry mouth." This is not even registering on my list of symptoms compared to the GI dysmotility, all the autonomic stuff besides the dryness. So there's some research suggesting that 26 to 67% of Sjogren's patients do not have the SSA or SSB antibodies. The difference in that percentage is just based on who did the study and what criteria they used to include people. And there's some increasing research suggesting that SSA and SSB may be markers of later stage disease. So it's kind of unfortunate that we're using these as the diagnostic criteria when we may be catching people sort of when it's almost too late to treat their disease. Neuropathy can be the presenting sort of obvious symptom in some people, particularly in the younger patients, according to the folks at Johns Hopkins who have a big Sjogren's Research Center. There's many, many different antibodies that have been identified in Sjogren's, and most of them are not commercially available. And notice muscarinic 3 receptor antibody is on there, and that is one of the 3 antibodies Dr. Vernino is testing for this weekend, because he found it in a small subset of POTS patients who may actually have some kind of overlapping Sjogren's-like problem, but we're not sure yet. And Sjogren's patients, probably about half of them, or more than half, have other autoimmune diagnoses, most commonly Hashimoto's, lupus, celiac, rheumatoid arthritis, vasculitis. It's a hodgepodge, like many autoimmune diseases. There's 2 main different diagnostic criteria that doctors use. The newer one is the American College of Rheumatology, but a lot of rheumatologists still like the American European consensus criteria. Both of them are meant for research, and then unfortunately those sort of really strict research definitions end up getting used in clinical practice, and they end up missing a lot of people who they could be treating and helping because they're sticking to the strict research definitions. Both of the criteria have various nuances and details, but the really boiled down essence of it is that you have to have dryness that's objective, not just your interpretation of dryness, and that you have to either have the antibodies or a positive FLIP biopsy. So in doing our study, we were hoping to maybe possibly identify some biomarkers that may help identify the cause or, I'm getting my 5 minutes. Okay, I better go fast, sorry. This is the cause of idiopathic dysautonomia in some of these patients. So our study population, Dr. Gudesbach has a very large private neurology practice on Long Island. We screened for carbonic anhydrase 6, salivary protein 1, and carotid secretory protein. These are not typical Sjogren's antibodies that most doctors test for, but they're part of a new panel that is available. It's called the SJO panel, S-J-O. You can just Google it and you'll find it. The panel also includes an option for the typical Sjogren's tests, which are SSA, SSB, ANA, and rheumatoid factor. So we included patients in the study who had dry eyes, dry mouth, and one or more, in addition to the dry eyes and dry mouth, one or more autonomic or neurological deficits, which many of them will be familiar to you: orthostatic intolerance, GI dysmotility, bladder dysfunction, weakness, cognitive impairments, balance and vestibular problems, gait problems, and sensory impairment. By design, all of these patients were SSA, SSB negative, and they had had a full workup, really detailed, looking for a cause of their neurological problem, and nothing could be found. So of the one-year retrospective of the chart review, we had 95 subjects that fit the criteria, 80% female, mean age 51. 10 of the 95 idiopathic dysautonomia patients were POTS patients, just by chance. So we found one or more of these antibodies in 41% of our 95 subjects, including 6 of the 10 POTS patients. So I don't want anybody to draw like really big conclusions, like 60% of POTS patients have these antibodies, because first of all, these are people who had confirmed neurological problems, which not everyone with POTS has a confirmed neuropathy. And these were also people who had reported either dry eyes or dry mouth, and not every POTS patient has that symptom either. 26% of the patients had more than one of the antibodies. And the youngest subject that had it was 13, which we thought was important because it shows that this kind of stuff can be brewing in young children. We compared the symptom profile of the people who had the positive antibodies and who didn't. And interestingly, it was almost essentially the same. The only thing that was statistically more significant was constipation was more common in the antibody-positive patients. So usually, that would make you ask 2 questions. Do these antibodies mean anything if everybody who didn't have the antibodies had pretty much the same symptoms? Or does it maybe mean that the other patients might have some kind of antibody problem too, we're just not looking for the right antibody if they had such a similar profile to the people who likely had an early form of Sjogren's? So prior research suggests that the antibodies are not meaningless, that they actually do have a meaning. This is work by a group up at SUNY Buffalo, rheumatologists and dental school folks. They've identified Sjogren's in animal studies in 2 different animal models of Sjogren's, and it shows up, the novel antibodies show up earlier in the course of the disease than the SSA and SSB do. They've also identified the same pattern in humans, and curiously, our study showed 41% of idiopathic dysautonomia patients reporting dryness having these antibodies, and their study showed that 45% of patients who met the criteria for Sjogren's but didn't have SSA or SSB also had these antibodies. So it's a very similar percentage. So what's next? We're hoping to do some small studies looking at these patients' response to immunotherapy, to track them long-term to see how long it takes for them to develop SSA or SSB, if they do at all. And then we're looking to do a larger POTS cohort. We actually were hoping to do it at this year's conference, but we had applied for a big grant to do it and we didn't get funded. But we're not giving up, we want to do that still. And we thought it would be really neat to actually compare it with the muscarinic antibodies that Bernini is doing. And so eventually it would be great to see some updating of the diagnostic criteria for Sjogren's overall to include some earlier biomarkers, because it seems to me that there's a lot of younger people who might have an earlier, milder disease, and if we could treat it early, maybe we can help them slow down their progression or maybe even prevent the progression to a more severe disease. That's it. Thank you. We have time for a few questions? So I'll take a few questions, and if Dr. Sandroni wants to come up, if anybody else had more questions. We have about 5 minutes for questions. Or maybe there's no questions. Oh, that's probably a better question for you than me.
Sjogren is extremely heterogeneous in severity. There are people that go through their entire life without even knowing they have it, and they're extremely mild. And there are people that are totally devastated. So unfortunately, it's a very difficult question to answer, because it can affect the nervous system, of course. Some patient can affect the central nervous system, with basically causing encephalopathy or even a psychiatric condition, all autoimmune. Can cause peripheral neuropathy that can be incidental, like a little bit of small fiber, a little bit of loss of sweating in the feet, which has no clinical consequences, or can be a more diffuse with autonomic involvement, etc. The biggest thing generally that gets the attention is the dryness of the mucosa. So the dry eyes, the dry mouth, the genitourinary region, and then joint involvement variably. But it's a big, big spectrum. I think indeed a lot of patients may travel, through the entire life without even knowing they have the diagnosis. So in terms of prevalence, it's probably a big underestimate. Because we pick up patients that presents with burning toes, and we just test them for Sjogren, and that's all they have. So
I wanted to add something to that. I went to the Sjogren's conference. They have Sjogren's Syndrome Foundation has a big annual conference, and it was about 700 patients, and it was big ballroom tables in a huge hotel, and it was a sea of white-haired old ladies, and there was one table for Sjogren's under 40, which is where I sat. And almost every single girl sitting at that table had been diagnosed with POTS before they were diagnosed with Sjogren's. And they knew me. This is really weird. I didn't go there knowing anyone, and they knew me from my POTS Girl blog. And they were like, "You're a POTS Girl?" And I was like, "Yeah, how do you know about that?" Because they all had POTS. And so maybe they didn't have POTS. Maybe they really had Sjogren's. I know there's some disagreement amongst the experts on that, but I think it's important to be aware of, if you have dryness, if you have neuropathy, you should talk to your doctors about getting tested for Sjogren's. That may not be what it is, but it's worth it to find out. Does anybody else have a question? Hi, Dr. Moak.
Yeah, the issue of Sjogren's is even more important young women who are potentially childbearing, because cardiologists will see some women who have Sjogren's even
Yeah.
what?
Neonatal heart block is one of the complications. It's usually associated with more like lupus-related Sjogren's, and so Sjogren's and lupus can often overlap. And that's something you'd want to be screened for if you had Sjogren's and you were thinking about getting pregnant.
I just want to point out that Venus Williams has Sjogren's. I believe she won the doubles championship.
Yes, I watched the match. She was actually, she publicly disclosed her diagnosis the same month I was diagnosed. And it was exciting. I mean, you never want someone to have a disease, but it was like, every disease kind of needs a celebrity. And I was kind of happy, but I was sad for her. But at the same time, she's doing so awesome. My friends and family are looking at me like, well, why aren't you playing at Wimbledon? But she's actually publicly said that she has it pretty mild and that she does. I don't even think she uses medication. But, for every person, whatever you're living with is hard on you, and you shouldn't compare. So.
I had a question about the genetic thing that was done, and if the different forms of treatment offer different results.
It's impossible to say at this point. The numbers are too small. Again, this was not a randomized study. It was an open label So it was truly preliminary just to see if there was anything there worth pursuing.
So the actual study, does it show which patients had which type of therapy?
Yes, yes.
On the GI thing, I luckily deal with this, but I have a friend that is in the very beginning. She has all these weird things, plus a lot of GI issues. Where can I suggest that she kind of starts with? I mean, she has, they have appropriate sense of variety, but a lot of things that seem to be very autoimmune. Where can I help her with the GIs, of course, the most troubling thing for her?
Well, needs to start in gastroenterology because they need a transit study, and then they needed to test for the antibodies if there is anything positive.
Well, we've posted this article that Dr. Sandroni spoke about when it first came out, and it was, I feel like the patient community didn't kind of get it because we know that there's a lot of people with gastroparesis, and they're not all going to have this, but we thought it'd be important for people to at least show it to their doctors. So we'll repost it when we post this video, so that people can look at the article directly. So, okay, we have 2 more questions, and I think we have to wrap it up.
Sorry. You said the average age of diagnosis was around 52 for presentation of children.
Mm-hmm.
If one had a lip biopsy early on in life, say in the late 20s or 30s, and it's negative then, is that an absolute that it's always negative?
No.
For those symptoms? Should it be possible to treat it in many years?
So there's research from the SUNY Buffalo group that's been working on these antibodies, and I'm sure there's research from other groups showing that your lip biopsy, as the disease progresses, your lip biopsy changes over time and gets worse. But it's really hard to predict if you don't have a positive lip biopsy when you're young. It's really hard to say whether it's going to get worse or not because you might not have Sjogren's at all. And I thought it was weird that mine came back positive and I really didn't have obvious dryness. And there's other people who have really severe dryness and their lip biopsy is almost normal. So it's tricky.
The SPR test that you were mentioning, I pulled up online real quick after you mentioned that. Is that something different than what that it is being done as far as antibodies being tested? Is that
You mean today?
right?
So these research antibodies that Dr. Vernino is testing, that's muscarinic 1, 2, and 3. That's not part of the show panel. It's totally separate.
Oh, no, I'm sorry. It's regarding the show panel. Are those the same antibodies that have been tested for the past couple of years, or just something new?
No, they've been commercially available since 2012, but they really didn't. Bausch & Lomb sort of recently bought the licensing agreement to do the marketing, and so they've really started to raise awareness about the panel. I think the initial company was kind of small. But those are the 3 sort of new Sjogren's antibodies. And they're not used to make a formal, definitive Sjogren's diagnosis. They're sort of just pointing in that direction, and your doctor should follow you and do a full exam.
Thank you. The Sjogren's study that you were referring to, do they do lip biopsies on those people?
So we actually haven't yet, but that's in the works. We're trying to get some of those patients. So I was one of the 95 patients, and I was lip biopsy positive, SSA, SSB negative, and I have 2 of the Sjogren's novel antibodies off the charts, even though I'm on immunotherapy. So, but we're going to send more of the patients unfortunately for them, they're getting lip biopsies.
Well, actually, there is also, you can do a nuclear scan of the salivary gland. It's unclear if it's as good as the lip biopsy yet, but that could be a first step. And that's non-invasive.
Thank you very much.
Thank you.